this is a scenario that would harm some, because there are truly, in my experience, individuals for whom the use of an opioid analgesic on a long-term basis, on a regular basis, made a huge difference in that person's ability to function comfortably and maximally well for that person. I think that if society moved in that direction, regrettably, it would take a backlash that would likely last. It would take years for there to be momentum to swing the pendulum in the other direction. I'm hoping that that won't happen, and I'm hoping that we will be able to work collaboratively to limit bad prescribing, recognize that there are those whose substance abuse and other issues create a precarious situation, or a more precarious situation for opioid or controlled substance prescribing, and that we need to bring an understanding to the table that I'm not a heart surgeon, so I don't do heart surgery. I think that rather than expect that every primary care physician who has no education, no background in opioid prescribing suddenly is forced as part of pain management to prescribe. I think we need to understand that opioid prescribing is rather complicated, it's rather complex, that we can become as skilled about doing it as possible. They're in the analogy to gaining the skills to do heart surgery, but we also should recognize our limits and not say to a patient, well, here's a month's supply of hydrocodone, and now I'm going to refer you to a specialist. But rather say, I'm not sure if this is the right approach for you. Before I prescribe, I'm going to send you to a colleague of mine who has more experience with this. I think that in no area of medicine is there absolute data. I think we have data to support the use of opioid therapy on a chronic basis for properly selected and followed individuals. I think that absolute number is lower than some might think, and we have to fix that gap.